Hey guys, Cody Warner with Idaho Medical Academy. Today we're going to be going over the medical assessment scenario sheet. We're going to go through it, teach it, and talk about all the steps and how you can crush your medical assessment. Okay guys, let's jump into this skill sheet. So as you look at it, I know that it looks very intimidating. There's a lot of words on there, there's a lot of steps. But the best way to break down this sheet is to break it into boxes. So you'll notice on your sheet, you have a box for scene size up. You have a box for primary survey. You have a box for secondary assessment and history taking, okay? So make sure you are breaking down those boxes, okay? One thing that I always tell my students is go home, get a note card, and write scene size up on it. Flip it over and write down your 5 or 6 points. Memorize that note card before you move on to the next box. Once you have that note card memorized, put it to the side, then go to your primary survey. Hit all the points. Don't get too into the weeds, just memorize each point in each step, okay? So once you're going through a scenario and you get stuck, you at least know that your next step is level of consciousness, or your next step is to check the airway. Memorize the steps before you start trying to put this to a scenario, okay? Memorize the skill sheet before you start working on the scenarios, okay? So the first box we're going to do is our scene size up, okay? Our scene size up starts as soon as we get the call. So if we're at the station and our bells go off, our scene size up begins. Dispatch is going to tell you what you're being dispatched to. So they'll say, Engine 4 and Medic 15, you're dispatched to a 50-year-old patient complaining of chest pain, okay? So with that information alone, I can kind of just go through my whole scene size up while I'm getting into the ambulance or into the fire engine. So first thing we do, we're always gonna have our PPE and we're making sure our scene is safe, okay? I'm gonna say that out loud to my proctor when I'm going through my test or while I'm practicing. I'm putting my PPE on in the ambulance or in the fire engine. I'm putting my gloves on. If it's like a code blue or a cardiac arrest, I'm gonna put my goggles on. Right? Like for firefighters, if it's a fire, we're going to be putting on all our turnout gear. It's the same thing for medicals. We have to put our PPE on while en route or just before we actually go to the call, so we're prepared. Okay, scene safety. Okay, we are not going to go into a scene that is not safe. Dispatch does an amazing job of asking questions to whoever's calling to ensure that our scene is safe. If that scene is unsafe or we want just that extra protection, PD will then be dispatched and we would then be told to stage upon arrival. Okay, so for things like an overdose or battery or domestic calls, we will most likely be staging. So we're not gonna walk into the scene and say, is this scene safe? Determine it for ourselves. And if it's not, then we leave. It's not how it works. So dispatch would then tell you. So if you have no information of saying stage, you can assume the scene is safe and relay that to your proctor, okay? Next thing we want to do is our NOI or our MOI. Okay, so is this a nature of illness call or is this a mechanism of injury call? For chest pain, that's a medical call. So I'd say my NOI is chest pain, or my NOI is shortness of breath, or my NOI is abdominal pain. Now, if this was a trauma, which we're not on the trauma skill sheet, but then I'd say my mechanism of injury or my MOI is a car accident or a gunshot wound, something trauma, right? So you need to determine what type of call you're going to. And then we're going to determine our number of patients. Well, how do I determine the number of patients if I haven't even made it on scene? Well, what did dispatch tell you? They told you you're going to a 50-year-old male with chest pain. So now I can tell my proctor, it sounds like I have 1 patient, okay? Now say you're dispatched to a CO alarm and there's 50 residents or multiple residents complaining of dizziness and headaches. So at that point, I'd ask my proctor, do we know how many patients we have, okay? But if I get dispatched to a 50-year-old male with chest pain, it's safe to assume I have 1 patient, okay? The next step, one thing you're always gonna do is request ALS, okay? Or make sure an ALS unit is coming. For testing scenarios, we are always going to ask for ALS backup, okay? It is always better to call them and not need them instead of need them then call them, okay? So get into good practice of requesting ALS early. And the last step in your scene size up is considering C-spine, okay? And that is just as simple as I'm not going to be considering C-spine, or I am going to be considering C-spine precautions for this patient, okay? And that's solely based on your NOI or MOI, right? Are you worried about C-spine on a patient with chest pain? Probably not, okay? So relay that to your proctor. Okay, again, that scene size up is done en route to our call. Now our primary survey is going to begin once we get on scene. So now I'm walking into the scene, I open up the door to their house or wherever we're at, and I'm going to take a general impression. Now here in school and in scenarios, we try our best, but we can't make the perfect scenario. So feel free to go ahead and ask your proctor. All right, I'm getting on scene. What is my general impression? Let your proctor paint that picture for you. Oh, you're in a well-kept home. You see a male sitting on the couch clutching his chest. Or you notice you walk in and there's beer bottles everywhere and needles and a bunch of white powder. So get your general impression, okay? From that, you can ask a couple extra questions if you'd like that might not have gotten answered by your proctor, or you can just roll with it, okay? So the next thing you're gonna do is assess level of consciousness. This is as simple as talking to your patient. Hi, sir, my name is Cody. What's going on today? And now are they going to respond to me? Okay, and this is where we're going to use our AVPU scale. Are they alert? So are we having a normal conversation? Are they looking at me when I talk to them? Are they alert to verbal? Right, I have to get close to them. Sir, can you hear me? And if he reacts to that, he would be alert to verbal. Do I have to use painful stimuli where I pinch his trap and get a reaction out of him? Well, now he's alert to pain. Okay, and if nothing, he would be unresponsive. Okay. So I'm going to ask my proctor, I'm going to say, all right, I'm going to walk up to my patient, I'm going to say, hey, sir, what's going on today? And I'm going to look back at my proctor. My proctor's going to say something like, all right, he looks at you and he says, he's having really bad chest pain. So I'm going to take a pause from the scenario, I'm going to look at my proctor, my patient is alert, okay? With this sheet, whatever you don't say, you don't get points for, okay? So make sure you are verbalizing every single step on this page so that your proctor can actually give you the point, okay? Now, with A&O questions, alert and oriented, if you don't think it's necessary, you have to tell your proctor. My patient seems alert and oriented, I'm going to continue with my assessment. Now, if I say, hey, what's going on, and my patient gives me a garbled sentence or a sentence that just does not make sense, I'm going to tell my proctor, I'm going to go ahead and ask my A&O questions. You know, what city are we in? Who's the president? What day is it? What's going on? Why am I here? Okay, to determine their orientation. Okay. So I got my general impression. My patient is alert. I'm going to move on to their chief complaint. Now, a chief complaint can be different from your NOI. Okay, so you got dispatched to chest pain. I say, hey, what's going on today, sir? And he says, my legs are they're just throbbing with pain. That's weird. I got called to chest pain, but now your chief complaint is leg pain. So don't think just because you're getting called to chest pain that your chief complaint is going to be the same. In this case, hey, sir, what's going on? He says, oh, my chest has just been killing me. It's safe to say that his chief complaint is chest pain. I'm going to, again, take a tactical pause from my scenario. I'm going to look at my proctor, and I'm going to say, my patient's chief complaint is chest pain. Okay? So this primary survey on an actual 911 call should take you close to 30 seconds max. Okay? You can gain a lot of this information by just looking at your patient and saying hi to them. In a testing scenario, this should take you around 2 minutes because you have a lot of things to check off, and this mannequin always looks the same and will always respond the same. So you've got to kind of do a deeper dive. So with our primary survey, we've got our first three, general impression, level of consciousness, and chief complaint. Okay, now we're going to move on to our ABCs. With your primary survey, this is when you are going to act immediately if something is wrong. Okay, this is when we're going to take care of it when we need to. Okay, so if something's wrong with the airway, I'm going to fix it. If something's wrong with their breathing, I'm going to fix it. If something's wrong with circulation, I'm going to fix it. Okay, so I'm not even going to worry about his chest pain until later on in the sheet and my secondary assessment. Okay, one thing we always see students do is, what's going on today? Because we're getting their chief complaint, I have chest pain. First thing they do is, well, how long has that been going on? Or have you ever had this before? Things like that. Don't do that because you're just going to get confused on the sheet. Stick to the sheet, stick to the steps. Okay, you're having chest pain, I'm going to move on to his airway, okay? If my patient is talking to me, it is now safe to assume that his airway is patent. And I'm going to tell my proctor that. Proctor, my patient's talking to me, his airway is clear and patent. okay? Now say my patient's not talking to me, I now need to intervene and open up the airway, whether I do a head tilt chin lift or do a jaw thrust, okay? Now from there, if it's full of spit or vomit or blood, I'm gonna suction it immediately. This is when we're acting immediately, okay? I wanna clear that airway, okay? He's talking to me though, my airway is clear and patent. I'm gonna move on to breathing, okay? With breathing, I want an RRQ, rate, rhythm, and quality. And it's just as simple as that, okay? I'm gonna look at my proctor. All right, I'm assessing breathing now. What's the rate, rhythm, and quality, okay? Proctor should give you an answer. They might give you a detailed answer. They'll say 20, regular, normal. Or they'll just say it looks normal, okay? That's fine. This is a primary survey. It's a quick down and dirty. Do I need to fix it or do I not need to fix it, okay? With that, you can now make the decision if you want to put on oxygen or not. So if your proctor says, oh, they're breathing very, very fast and very shallow, it is now safe to put on a non-rebreather at 10 liters a minute or 15 liters a minute. If you want to put on a nasal cannula at 2 liters a minute or 4 liters a minute, that's fine as well. You just need to explain why you're doing what you're doing. Oxygen is not going to hurt your patient, so it's safe to go ahead and put oxygen on. In a testing situation, I recommend everybody does 10 liters per minute on a non-rebreather. Now with that being said, in the field, it is very rare for me to put on a non-rebreather. Nasal cannula typically does the job, but with NREMT and testing standards, always safe to just go big or go home. So I'm telling my proctor I'm going to go ahead and put on oxygen, or I'm telling my proctor I don't think oxygen is necessary at this point. Again, if you don't say the step, you are not going to get the point, okay? So then I'm going to move on to circulation. My patient is conscious, so I'm going to check a radial pulse. I look at my proctor and say, hey, can I get a rate, rhythm, and quality on the pulse? Okay. Again, your proctor might say it's 100, strong and normal rhythm. Or your proctor might say it is irregular and feels thready, right? So you are just going to roll with it. Can we do anything for a fast heart rate? Probably not. Or an irregular heart rate? Probably not, especially at the EMT basic level. But what I can do is if they don't have a pulse, I can start compressions, okay? This is just gaining intel at this point. With circulation, I want to look at their skin. I want to look at their skin color, temperature, and condition, okay? That's going to tell you a lot about your patient. I'm not saying always, but if my patient is pink, warm, and dry, typically they are healthy. They're not as sick, you could say. If they are pale, cool, and clammy, something is absolutely going on. It'll be your job to figure that out in your secondary assessment, okay? So for scenario's sake, we'll just say he is pale, cool, and clammy, which is a sign of shock. So with that being said, I want to make sure I put oxygen on this patient. I want to keep him warm. I want to keep him in a position of comfort, okay? Typically, we like to lay patients down if they're in shock. But if I have a chest pain patient or a shortness of breath patient, typically that will make it worse. So position of comfort, okay? Last thing we're going to do in circulation is check for any major bleeding, okay? This could be something obvious. We walk up to our patient, we see bleeding. If it's major bleeding, we want to jump on it quick and fix it, okay? If we see major bleeding, again, not very typical in medical patients, more on traumas, but we want to stop that bleeding immediately. So ABCs then turns into CAB, okay? After that, we've got our primaries out of the way, our ABCs. We fixed what we could fix, or we didn't have to fix it, whatever it was. But this patient is technically stable on ABCs. I don't have to do CPR. I don't have to bag them. I don't have to place an OPA or an NPA, okay? So now I'm going to go ahead and assess my vital signs. Okay? I'm going to look at my proctor and say, I want to check vitals. I want a blood pressure, and I'm going to wait to hear what my blood pressure is. I want a pulse rate if I haven't gotten it in circulation. I want an SpO2, and I also want a breathing rate if I haven't gotten it in that B, okay, when I was doing my ABCs. Again, now if my proctor gave it to me when I asked for breathing, rate, rhythm, quality, and circulation, rate, rhythm, and quality, I'm just going to reiterate. All right, my pulse was 100, my respiratory rate was 20. What's my blood pressure? What's my SpO2? And don't be afraid to ask for a BG. It's a very, very simple procedure to get a blood glucose. Typically, blood glucose levels are normal, especially if your patient is alert and oriented. But it's always a safe bet to just check a blood glucose, okay? Now, we need to make a decision if we are going to transport, load and go, because this is a high priority patient, or if we're just going to stay and play. Little tip here for testing, all your patients are going to be high priority. So get in the habit of, I have my vitals, this patient is high priority, we're gonna get him into the ambulance and we're gonna transport to the ER. So now that we are into the ambulance, we are transporting, we wanna gain some information on this guy. Now you might be thinking, well, what about that chest pain that he's been complaining about? It feels like we're taking forever to get to it. And yes, that is true. This is a testing scenario and that's okay. Okay, so just be patient. Remember, you are on a checklist, okay? So now we're gonna move into our sample history and we're gonna gain some intel on this patient. It could absolutely help us kind of discover what's going on with his chest pain, or it might give us nothing at all, okay? So we're gonna go through that acronym. I'm gonna ask, so S is my signs and symptoms. My patient's pale, cool, and clammy. He's complaining of chest pain. Heart rate's a little elevated. Those are my signs and symptoms. I'm partially gonna say, good, and he's gonna check the S. Okay, then I'll move on to my A. Does my patient have any allergies? Proctor might say, nope, or they might say, yeah, penicillin. Okay, does that help me right now? No, it doesn't, but it's good information to have. Or my proctor might tell me they're allergic to aspirin. That's good to know because my patient has chest pain. In the back of my head, I'm thinking I'm probably going to give aspirin. Now I just figured out that they're allergic to aspirin, so I'm going to make sure I do not give aspirin. Okay, I'm going to move on to medications. What medications does my patient take? Okay, keep it general so you can get everything in. Now, if your proctor is telling you medications that you've never heard of, feel free to ask, what is that used for? Okay, it might be totally benign. Your proctor might even say, he's not sure, which means you can just move on from that medication. You don't have to worry about it. Okay, now this is where you want to listen for keywords. So your proctor might say they take a nitro and an aspirin. Oh, okay, and go ahead and feel free to have a follow-up question. What do they take that for? Oh, well, he takes aspirin after his first heart attack, and he takes nitro because of the heart attack as well. Perfect. My next follow-up question is, have you taken your aspirin or nitro today? Yes or no? Okay, it's just information. It's just intel. I'm going to move on to P. Well, sir, what is your past pertinent history? Okay, and I want to know everything. Okay, but I'm only going to pay attention to what's important. So if he tells me he had surgery on his toe 8 years ago, back of my head. If he says, well, I had a heart attack, I want to know when it was. If this chest pain right now feels like that last heart attack, and what was done for him. Okay, again, it might help you, it might not. L, last oral intake. This is important because the hospital, if this guy has to go into surgery, the hospitals want to know when's the last time they ate because they don't want him vomiting, basically. This is also important for our abdominal pain patients or our blood sugar patients, types like that. So it's an important question to ask. It typically gets forgotten, but it is an important question to remember. And then E, events leading up to, which is simple as, what were you doing when this started? Okay. Oh, I was just sitting here watching TV. Okay, so now as an EMT, I'm thinking, you were sitting there watching TV and now you have this chest pain and you're super sweaty and you're super pale. Something is most likely going on and I got to discover what that is, okay? So I'm done with sample. Again, it's just those letters, but feel free to ask follow-up questions to anything you want to gain more intel on your patient. Now you're going to move on to your secondary assessment. This is kind of the bread and butter of this whole sheet, okay? This is where you show how knowledgeable you are, okay? You'll look on your sheet and you're going to see a ton of boxes. You're going to see cardiac, you're going to see neuro, you're going to see shock, you're going to see abdominal, GI, GU. And then you see a bunch of points in those boxes, okay? Those points are just questions for you. You do not have to memorize all of those little points. One thing we always see with students is they get to that secondary assessment and they say, all right, my patient's complaining of chest pain. I think it's a cardiac emergency. And then they freeze. I want to give aspirin. Well, pump the brakes. You don't even know what's going on. You didn't even assess this patient, okay? So now as our secondary, now it is time to dive into his chest pain or dive into the shortness of breath. And you need to ask appropriate questions to get full points. But not only just the full points, you need to ask good questions to figure out how you're going to actually treat this patient, okay? One mnemonic we use for chest pain, I personally love it for all call types. You can kind of bend the mnemonic however you want to to ask certain questions, but it's OPQRST. So onset, provocation, quality, radiation, severity, and time. That is great for pain, but again, I use it for shortness of breath. You can use it on stroke patients. But onset, I want to know, is this acute or is this chronic? Has this chest pain been going on for 2 months, or has this chest pain been going on for the last 20 minutes? Okay, now if it's acute, kind of little hairs on the back of my neck stand up, and I'm thinking, this is an actual medical emergency. He says, I've been dealing with it on and off for 2 months. I can kind of take a deep breath, and I'm like, something's going on, but it's not emergent if he's been living with it for 2 months, okay? Then I'm going to move on to P, provocation. I want to know if anything makes it better or worse. Does your chest pain get better when you lay down? No, it does not. Does it get better when you stand up? No, it does not. It stays the same. What if I put a little pressure? Does it get worse? No, it does not. It stays the same. If his pain is staying the same constantly, it is most likely cardiac pain. Okay, now if I push down and say, does that make it worse? He said, yeah, that's way worse. It's probably actual muscle. Okay, so this is where doing a thorough assessment is so important, because you might be treating for a heart attack when this patient just has a sore or pulled chest muscle. Okay, so to get full points, you need to be doing a good assessment. All right, just like in math classes, your teacher always says, yes, you got the correct answer, but you did not show your work. That's where we're at with this. You need to show your work of how you were able to decipher what his actual medical condition is. Now, with that being said, we have plenty of patients that we sometimes have no idea what's going on, okay? We're going to keep them stable. We're going to do our best. We're going to treat what we can. We're going to get them to the hospital, because the hospital can do way more extensive tests on our patients. So don't feel like because you can't come with a diagnosis that you're going to fail the sheet. That's okay. For testing scenarios here at IMA, we will give you a legit call to where you can actually figure it out. We're not here to trick you. Okay, so do a good assessment. Now, if you just say, are you having chest pain? Yes, I am. Okay. I think he's having a heart attack. I'm going to give aspirin. Your proctor is probably going to give you 0 points for that whole secondary assessment, because you did not assess anything. Okay, right? Shortness of breath patient with an allergy to bees. You're like, well, they're short of breath and they're allergic to bees. I'm going to give epi. Well, did they have hives? Was there any swelling? What did their lung sound like? So you're just giving epi to anybody, and that can actually hurt your patient. Okay. So you've gained all your intel. You actually think this is a heart attack because you did a good, thorough assessment. You used some differential diagnoses. You ruled some out, you ruled some in, and you think that your patient's having a heart attack. Or you think your patient is having anaphylaxis or an asthma attack or appendicitis. How are you going to treat it? Okay, so now you're going to make your field impression of this patient. Okay, so I'm now going to take a tactical pause. I'm going to look at my proctor. I'm going to say, acute onset of chest pain. It's radiating. Nothing makes it better or worse. 10 out of 10. Feels really, really tight around his chest. Started about 10 o'clock. I think it's a heart attack. He's had one in the past. My field impression is a heart attack or an MI. My interventions, I'm going to go ahead and give 324 of aspirin because he's not allergic. And then I'm going to go ahead and give nitro. Now, once you get to your interventions, you need to know your medications. So be prepared for your proctor to say, okay, what's this medication going to do for him? What's your dose? What are the contraindications? Okay, things like that. Same with nitro. Especially with nitro, be prepared for your proctor to say, make sure you double check the blood pressure or something like that, okay? So do your interventions, and then once you're done with your interventions, you kind of fast forward, okay, so I've given my meds, I now want to do a reassessment, okay? And I'm reassessing this patient every 5 minutes because they're a high priority patient. Your proctor is going to look at you and say, okay, now you need to tell your proctor what you're reassessing. Easy peasy, I want all my vitals again. I want to hear every single vital sign that I've already taken. I want to hear them again, okay? Then I'm going to look at my patient and I want to reassess how he's doing. Is that chest pain getting any better? Or is that chest pain getting any worse? Is he looking more tired, or is he looking more awake? Or is he staying the same? Okay, this is what a reassessment is. He's still having that chest pain, I might be able to give more nitro. Okay, so this is why you're doing a reassessment. Typically in a testing scenario, your proctor is probably going to say, vitals are looking good. He says the chest pain's feeling about the same. And you say, okay, sounds good. and then we're gonna move on to our handoff report, okay? Here in the testing scenario, you're actually gonna give a radio report to the hospital. Radio reports are quick, down and dirty. We'll practice this a lot in class. You can YouTube them as well. There's tons of different mnemonics and acronyms out there that you can use, but I just keep it kind of simple. We'll call the hospital, say, hey, we're coming in, 50-year-old male, complaining of chest pain, possible heart attack, history of heart attacks. We have given him aspirin and nitro with a little bit of relief. Current vitals are as follows. Give your vitals, and then give him an ETA. We'll be there in about 5 minutes. Do you have any questions? Okay. Again, that's something you can practice on your own. It's pretty simple. You're just kind of plugging in information. So figure out an acronym or figure out a mnemonic that works for you. And then once you give your handoff report, you are all done. Okay, guys, also a few questions we typically get asked on this skill sheet right above your secondary assessment. There's a point there that says assesses, identifies, and treats. That is basically a precursor of your next 3 steps, okay? So it's just there to tell the proctor what you're about to do. Feel free to tell your proctor, okay, I'm now gonna assess, identify, and treat. I'm gonna jump into my secondary assessment, okay? So you're gonna assess, you're gonna do your full assessment on your patient, asking all those questions. You're gonna identify, meaning what is your field impression? Oh, I think this patient's having a heart attack. And then you're gonna treat. My interventions are this, okay? If you look a little bit lower on that sheet, just under your secondary assessment, it says ask clarifying questions, okay? That is when we are doing our assessment and we're making our differential diagnoses, right? So say I have a shortness of breath patient. It could be anaphylaxis, it could be asthma, it could be anxiety, along with a bunch of other things, okay? So now I'm gonna ask clarifying questions to determine what it actually is. So I'm listening to lung sounds. Okay, I hear wheezing, okay? That could be anaphylaxis, that could be asthma. So I don't think it's anxiety anymore. I'm gonna look on the skin. I'm not seeing any hives. Open your mouth. I'm not seeing a very swollen tongue. They didn't eat anything that they're allergic to. They didn't get stung by a bee. I'm not seeing any hives. I'm not seeing any swelling. I don't think it's anaphylaxis. I have now clarified that I don't think it's anaphylaxis. I think this is asthma. That is my field impression, and I'm gonna treat with my interventions. I'm gonna go ahead and give albuterol. Okay, guys, that was your medical scenario assessment sheet. If you have any other questions, give us a call or shoot us an email or go ahead and look up our website.